Welcome to QuickIM with Dr. Addy, your go-to channel for reviewing clinical concepts or preparing for board exams. Please note, this video is for educational purposes only. This presentation provides a comprehensive yet focused review of Graves' disease. Graves' disease is an autoimmune disorder leading to hyperthyroidism. It is the most common cause of hyperthyroidism in iodine-sufficient regions. It predominantly affects women, with a female-to-male ratio of approximately 7:1, and typically manifests between ages 30 to 60. The pathophysiology of Graves' disease involves sensitized T cells stimulating B cells to produce thyroid-stimulating immunoglobulin or TSI autoantibodies. These autoantibodies bind to and stimulates TSH receptors, leading to excess thyroid hormone production. This results in hyperthyroidism and suppressed TSH levels through negative feedback. TSI activity also stimulates orbital fibroblasts, leading to the characteristic ophthalmopathy seen in some patients, and fibroblast activation in the dermis can cause pretibial myxedema. Genetic susceptibility is supported by associations with HLA-DR3 and CTLA4 gene polymorphisms, underlining the disease's complex immunogenetic basis. Graves' disease presents with diverse clinical features across systems. General symptoms include weight loss and fatigue, while cardiovascular effects involve tachycardia and atrial fibrillation. Endocrine symptoms feature goiter and menstrual irregularities. Neuropsychiatric and gastrointestinal manifestations further complicate the clinical picture, while ophthalmologic involvement such as proptosis, lid lag, and pretibial myxedema are more specific. Understanding the multisystem presentation is critical for early diagnosis and to avoid missing atypical cases. The diagnostic workup begins with suppressed TSH and elevated free T4 and/or T3, though some cases exhibit isolated T3 elevation in T3 toxicosis. Serologic confirmation involves detecting TSIs, which are highly specific, or TRAb, which encompass stimulating, blocking, and neutral antibodies. Anti-TPO antibodies may be present but lack specificity. Functional imaging via radioactive iodine uptake, or RAIU, shows diffuse increased uptake in Graves' disease and helps distinguish it from other causes of thyrotoxicosis, but RAIU is contraindicated in pregnancy and breastfeeding. Ultrasound reveals diffusely enlarged hypervascular thyroid tissue and is particularly useful during pregnancy or when nodules are present. In Graves' disease, radioactive iodine uptake, RAIU, shows diffuse increased uptake due to uniform overactivity of the entire gland, distinguishing it from thyroiditis or exogenous hormone use, which show low uptake, and from toxic nodules, which show focal uptake. Thyroid ultrasound with Doppler reveals a diffusely enlarged gland with markedly increased vascularity, a finding described as thyroid inferno, which helps differentiate it from silent thyroiditis, which shows normal or low flow and nodular disease with focal changes. Treatment options for Graves' disease aim to control excessive thyroid hormone production, relieve symptoms, and prevent complications. Modalities include antithyroid drugs like methimazole and propylthiouracil, radioactive iodine therapy, and surgical thyroidectomy. Adjunctive therapies such as beta blockers and glucocorticoids support symptom management, ensuring comprehensive care. Antithyroid medications belong to a drug class called thionamides, which includes methimazole and propylthiouracil. They inhibit thyroid hormone synthesis by blocking thyroid peroxidase. Methimazole is the first-line agent due to efficacy and safety, while propylthiouracil is reserved for first trimester pregnancy or thyroid storm. Side effects range from mild rash to serious agranulocytosis or hepatotoxicity. Methimazole is teratogenic when used in early pregnancy, associated with rare birth defects like aplasia cutis and esophageal atresia. Long-term remission is possible, but relapse is common after drug discontinuation. Radioactive iodine therapy, RAI, ablates thyroid tissue using oral iodine 131, indicated for moderate to severe cases or relapse after antithyroid drugs. It is a definitive, non-surgical therapy, but contraindicated in pregnancy, lactation, and severe orbitopathy. While curative in most cases, it often results in permanent hypothyroidism requiring levothyroxine. Some patients experience transient worsening of hyperthyroid symptoms, and therapeutic effects may be delayed for weeks. Pretreatment with antithyroid drugs is often considered in high-risk cases to mitigate acute hormone release. Surgical thyroidectomy involves total or near-total thyroid removal, indicated for large goiters, cancer suspicion, or failure of other therapies. It is also indicated in moderate to severe orbitopathy when other treatments fail. It offers rapid control of thyrotoxicosis and avoids radiation exposure. However, surgical risks include hypothyroidism, hypoparathyroidism, and recurrent laryngeal nerve injury, necessitating lifelong thyroid hormone replacement, as well as calcium and vitamin D supplementation. Recurrent laryngeal nerve injury typically presents with hoarseness, a weak or breathy voice, and occasionally stridor or aspiration. Adjunctive therapy for Graves' disease includes beta blockers for relief of adrenergic symptoms like tachycardia and tremor, glucocorticoids for control of inflammation and autoimmune activity, especially in orbitopathy and thyroid storm. Iodine temporarily inhibits hormone release in thyroid storm. Cholestyramine aids fecal excretion of thyroid hormones, while acetaminophen and selenium provide supportive care. These treatments complement definitive therapies by addressing specific symptoms. Complications of Graves' disease include thyroid storm, a life-threatening exacerbation of thyrotoxicosis, and ophthalmopathy, which may worsen with RAI therapy. Relapse is common after stopping antithyroid drugs, and hypothyroidism may result from treatment, requiring lifelong levothyroxine therapy. Graves' ophthalmopathy, or thyroid eye disease, is an autoimmune inflammatory disorder affecting the orbit. It is the most common extrathyroidal manifestation, significantly impacting quality of life and threatening vision. Smoking is a major risk factor. The pathophysiology involves TSI antibodies activating fibroblasts, leading to glycosaminoglycan deposition, edema, and orbital tissue expansion. Clinical features of Graves' ophthalmopathy include early symptoms like dry eyes and photophobia, with classic signs such as proptosis and eyelid retraction. Diplopia from extraocular muscle involvement and exposure keratopathy are common. Optic neuropathy, though rare, poses a vision-threatening risk and requires urgent intervention. Graves' ophthalmopathy follows a biphasic course with active inflammatory and inactive fibrotic phases. Assessment involves the Clinical Activity Score, CAS, and imaging like CT or MRI to evaluate muscle enlargement and optic nerve compression. Phase differentiation guides therapy, as active disease responds to immunosuppression, while inactive disease requires rehabilitative surgery. Management of thyroid ophthalmopathy includes achieving euthyroidism, smoking cessation, and eye lubrication. For mild active cases, selenium supplementation may be beneficial. Active moderate to severe disease is treated with IV steroids, teprotumumab, other immunosuppressants, or orbital radiation. Sight-threatening disease mandates urgent IV steroids and possibly decompression surgery. In the inactive phase, surgical interventions such as strabismus or lid repair are considered. Thyroidectomy may be indicated for rapid disease control, with close follow-up essential to prevent worsening. It is important to note that radioactive iodine therapy may worsen Graves' ophthalmopathy by triggering an immune flare, particularly in patients with active eye disease or high TSH receptor antibody levels. Thyroid storm is a rare but life-threatening complication of Graves' disease, marked by extreme thyrotoxic symptoms. It often occurs in untreated or inadequately treated cases, triggered by stressors like infection or surgery. Clinical features include hyperthermia, tachyarrhythmias, CNS disturbances, and GI symptoms. Hepatic dysfunction may also occur. This endocrine emergency requires prompt recognition and aggressive treatment to prevent multi-organ failure and death. Diagnosis of thyroid storm is clinical, supported by very low TSH, elevated T3/T4 levels, and supported by the Birch-Wartowski score. Treatment involves immediate hormone synthesis inhibition, hormone release blocking, and supportive care. Propylthiouracil inhibits thyroid hormone synthesis and peripheral conversion of T4 to T3. Iodine inhibits the release of thyroid hormones, while beta blockers control adrenergic symptoms, with propranolol preferred due to its additional effect of reducing peripheral conversion of T4 to T3. Glucocorticoids reduce inflammation and T4 to T3 conversion. Supportive care is vital. Mortality can be over 90% without treatment, but drops significantly with prompt intervention. The summary table outlines treatment options for Graves' disease, including antithyroid drugs, radioactive iodine, surgery, and adjunctive therapy. Each option's main use, advantages, and limitations are detailed, providing a comprehensive overview for decision-making. This table serves as a quick reference for clinicians managing Graves' disease. This high-yield Q&A table highlights essential board-level facts about Graves' disease, covering diagnosis, treatment, and complications. It identifies thyroid-stimulating immunoglobulin, TSI, as the most specific antibody and diffuse increased uptake on RAIU as a classic imaging feature. Clinically, exophthalmos is noted as the most specific sign, and agranulocytosis is emphasized as the most serious hematologic side effect of methimazole. In the context of pregnancy, RAI therapy is contraindicated, and PTU is preferred during the first trimester due to lower teratogenicity. For moderate to severe ophthalmopathy, IV glucocorticoids are first line, while thyroid storm requires a multi-drug approach including beta blockers, PTU, iodine, and steroids. In cases of large goiter or suspicious nodules, thyroidectomy is favored. Lastly, beta blockers like propranolol are used for symptomatic control of adrenergic manifestations such as tremor and palpitations. This table serves as a concise but comprehensive review for exam preparation and clinical reinforcement. For more educational content, like, share, and subscribe to QuickIM with Dr. Aid. Your support helps us create even more valuable content for you.